Thank you again. It will last not too much, I promise. And about information technology, as the commander said before, COVID-19 showed us that we can save time and be more effective. And we had a pandemic to understand that, because if I can send an electrocardiogram to the cardiologist in his department, I save time, he saved time, but moreover, the patient could be treated soon about his pathology. And to avoid to be the COVID-19, we had also some devices linked with the Bluetooth and with the smartphone to check people at home with temperature, blood saturation, heart rate, and respiratory rate. So I think that COVID-19 in this case boosts us to understand that we had to do more and more about information technology, and the presentation about what's happening in Athens now about this system is really impressive. We will save more time because our lighthouses are the European guideline on management of major bleeding that are really effective, and the tactical combat casualty cares. And in the last edition, there are some interesting items that we will see. Before I show you this slide where a quarter of our casualties are potentially survivable, and here we can focus that almost all the potentially survivable casualties died about hemorrhage. So we have to do more, as I said before, about the occult shock to monitor better the decrease of our systolic pressure, to understand who is who's having an internal bleeding because he's a non-responder after our microfluid challenge. And we start on what is scientific proof about tranexamic acid. This is another stone, is very important. We have not to fear to use it, but we have to remember that we have to use not beyond 3 hours to avoid the paradoxical effect that increase the bleeding. So tranexamic acid, perfect, we have to give, but after 3 hours is better not to give it, because we are going to worsen the patient. Because it's not true that one solution fits all. But before I said you that in the new edition of the Tactical Combat Casualty Care, there are something, a new topic, and here resuscitate with whole blood, or if it's not available, red blood cells and platelets and plasma with the 1:1:1 ratio. So what's new? Now, even the tactical combat says that whole blood is a feasible solution. And when we speak about whole blood, that is optimal, and this is a paper from Spinella, and Spinella is a former US military physician, now is one of the world experts about whole blood and in the artificial blood oxygen carrier. And he said something very interesting about hypocalcemia, or better, when we give transfusion, we think about calcium, obviously. But in a hemorrhagic patient, when we don't have, for example, blood, I never think about to correct the calcemia, because I was focused in other thousands of things. But the calcemia plays a very important and focal role during resuscitation and in muscular activity. Before I spoke a brief about the lyophilized plasma, and here I report an interview that I did to the Professor Glasberg, is a Surgeon General of the Israeli Medical Corps, and I asked him something about the lyophilized plasma. Why we are going to use it in the pre-hospital setting, or the fact that if we use it as a fluid challenge or as a fluid with coagulation factor. First, he said me, okay, I'm going to use it as a physiological resuscitation fluid to avoid pathology on glycocalyx and endotheliopathy. And the fact that I have, even inside this physiological fluid, an amount of coagulation factor, for me, is a benefit, is a bonus. So that's an important view. I skip those papers that I showed you before. And here is interesting because they underline that blood products are precious. So we had to focus and to reflect when you use it. And maybe when we have a short time of transportation, the pre-hospital use is not a big advantage. I skip, sorry, the FNT that I forgot to remove. And I go straight. This slide that I show you, I don't want to replicate, but show we have base excess here, base deficit. And here I introduce you an interesting classification of the hypovolemic shock following the deficit base. So here it matches very well with the, for example, the ATLS classification of shock. It's very quicker, and if you are a blood sample analyzer, we can do it very, very quickly. Now, this is not a joke. This is a travel agency that organizes interesting travel all around the world: Kurdistan, Kashmir, Mesopotamia, Iraq, South Pakistan, and also Afghanistan. I was there in 2016. And they told us an amount of tourists were eaten by a rocket attack, RPG's attack, sorry. And so in our RACHEDI hospital in Herat, we welcomed 10 injured people. Now, you have to understand that 10 injured people, if you are going to face 10 bleeding people, is a mass casualties even in a normal hospital. So you have to understand that what could happen in a RACHEDI hospital. And so there we started with the, we activate the working blood bank. So we had all people with different blood type, especially with the zero negative type, ready to start the transfusion. Now, a little step back, because to understand that if I'm not going to give blood, if I'm going only to give crystalloids or other fluids, I'm going to do a damage to our vessel, and our vessel are between 4,000 and 7,000 square meters. So if I have a blood failure, I have surely a multi-organ failure, and so I'm going to lose, lose the patient. So it's important understand the kind of trauma and to avoid endotheliopathy. And with a forward use of plasma and blood, I can allow the patient to reach our surgical room in the right time, as shown before with this slide about the medevac, to guarantee a better outcome. So every time is not only a matter of what I'm going to give, but even when. We can also refer to COVID-19. We still don't have a therapy, despite the monoclonal antibody. Okay, perfect. But another important consideration is when is better to start the therapy for COVID-19, because even in the first wave of this pandemic, we received people that arrived in the hospital with lungs that are more or less bars, useless. So it's important here, even one time, the timing or what we are doing and how we approach to the patient. Here, so it's important to remind that what we do overseas during our operation is an hemostatic resuscitation, because we have do a damage control management based on hemostatic resuscitation, and we have to do a lot of things with few assets. This is the flowchart that I showed you before, and I think that the pre-hospital use of whole blood lyophilized plasma could be interesting, and this is another alternative, interesting, very easy, because I go to stop the hyperfibrinolysis, giving not beyond 3 hours the Tranix. I can support the clot formation with a large amount of fibrinogen, as Megale said, and if I have, there is concerns about the prothrombin complex. And about the extreme measure I showed you before this slide, I leave other things for another time, but the good news, this is a very important Italian journalist that said every time that there are a lot of things that are going worse and worse in Italy, and she's going to finish every report with a good news that in Italy we started, even we have low problem, but we started with blood on board in Tuscany and even in North Italy. And I think that the pre-hospital use of blood and plasma could be feasible if we find a good protocol to understand the right cutoff, even in urban area. Thank you. The last thing I say that in Italy, the blood donor are volunteers, so there is no a business about blood. Is the National Blood Center is a public institution, so sometimes where there is no business, it's more easier to organize the service. Thank you, and sorry if I was long. Thank you.